Hello students, welcome to today's class. I'm Bernisha, lecturer from Emmanuel College of Pharmacy. Today I'm going to discuss about iron deficiency anemia from pharmacotherapeutics disease. Iron deficiency anemia is one of the common disease usually occurs in girls and this iron deficiency anemia in this video we are going to learn about what is iron deficiency anemia, how we will management the deficiency and what are the pathophysiologies, their symptoms, etc. Let's get into the video. First, let's see what is anemia. Anemia is defined as the reduction of the hemoglobin concentration or red blood cell volume below the reference level for the age and sex of the individual. Usually, there will be some of the certain standard values which will shows that every individual must shows have some of the normal value of the blood in our body. So if the persons in usually in female that will be around 13.5 to 12%, lower limit will be 12, and in for usually it's around 12 to 14, and for male also it's around 14, it's about greater than females. And usually in this time we have to notice that when there is any reduction or low level in the hemoglobin, its condition is known as anemia. Usually this there will be the changes in the normal value for based on the age and the sex of an individual. So in this tabular column we have learned we can see that for up to 0.5 to 0.5 to 4 years children there will be around 12.5 percentage of hemoglobin, and 5 to 7 it will be 13, 8 to 11 it will be 13.5. Above the 12 to 14 for females it will be 13.5, and for male it will be 14, and for above 18 to 49 it will be 14 for female and 16 for male. And next one is, let's see what is iron deficiency anemia. Iron deficiency is the most of a widespread and common nutritional disorder in the world. It's about 30% of the global population has iron deficiency anemia, and most of them live in the developing countries. This iron deficient anemia is known as there will be the deficiency in iron, that is the iron hemoglobin content in the blood. Anemia means there will be the reduction of blood, and but here iron deficiency totally shows that there will be the deficiency of iron in the blood. So here we can note that the full-time newborn babies contain 0.5 gram of iron, and compared to 5 gram of ions in adults. It is necessary to absorb approximately 1 milligram daily to maintain positive iron balance in childhood. Usually in a day-to-day life, in a proper childhood, we have to absorb approximately 1 milligram to maintain the positive iron balance in a childhood. Because of less than 10 percentage of the dietary iron usually is absorbed, a dietary intake of 80 to 8 to 10 mg of iron daily is necessary to maintain the iron levels. And here also the breastfed infants have an advantage because they absorb iron up to 2 to 3 times more efficiently than the infants feed with cow's milk. Next is, what is the role of iron? What does the iron does to our body? Role is transport and storage of oxygen in form of hemoglobin and myoglobin respectively. Usually this iron may carry the oxygen which will be very much important for our day-to-day life. This oxygen in the form carried in the form of hemoglobin and myoglobin has prosthetic group in number of enzymes, cytochromes and cyclooxygenase, etc. It is helps in maintaining healthy immune system. Usually, these iron are useful to maintain the healthy immune systems as a reserve of ferritin and hemosiderin present in the liver, spleen, and bone marrow to maintain the iron homeostasis. So here we can see that usually this iron is a compound composition of ferritin and hemosiderin. This ferritin and hemosiderin is mainly present in the liver, spleen, and the bone marrow, which is with these ferritin and hemosiderin is very much important in maintaining the iron homeostasis. Next one is source of iron. We have to know what will be the sources of ions. Heme. Heme iron. It is mainly derived from the animal source, which includes meat, fish and poultry. Our bodies easily absorb this type of iron. Usually the source of iron is mainly in meat, fish and poultry. Non-heme iron plant sources includes dried beans, peas, lentils and some fruits and vegetables. And here have both cow's milk and breast milks are low in iron, around 0.2 to 0.5 milligram per liter. However, the iron in breast milks offers greater bioavailability because the breast milks have high content of lactoferrin, high levels of vitamin C and lower level of calcium and phosphate. To prevent the iron deficiency anemia, a balanced diet containing both the heme iron and non-heme iron sources should be consumed. Breast milk remains an excellent source of highly absorbable iron for infants. Heme ions from the animal foods is absorbed best, while the non-heme ions from the plant food is absorbed less efficiently. Although breast milk contains the little iron, its ions is absorbed very effectively by the infants. So this heme iron and non-heme iron is very much important for our balanced diet. Here the iron absorptions mainly depends on the three main factors. Iron absorption is the process by which the iron from the food enters through the bloodstream and it is utilized by the body for the hemoglobin synthesis and oxygen transport. Here mainly it is depends on the three main factors. For that, first is body stores of iron, next one is rate of erythropoiesis and the third one is iron requirement of the body. First one is body stores of iron. When the iron stores are low and absorption increases. When the body iron stores are low, the absorption increases. And the next one is rate of erythropoiesis. Increased red blood production requires more iron. So when there is a high red blood cells production, it requires more iron. And the next one is iron requirement of the day, that is iron needs of the body. The absorption increases during the growth and pregnancy and anemia. Usually in this anemic condition there will be the large intake of or need of iron in our body. Several factors increases the iron absorptions including the vitamin C, fruit juices, lactose, amino acids such as cysteine, lysine and histidine or gastric hydrochloric acid. These factors help to convert it into a form that is easily absorbed by the intestine. Some factors which decreases the iron absorption such as phytates found in cereals and grains, tannic acid which is present in the tea and coffee, calcium salts and phosphates, prolonged alcoholia, alcohol achlorhydria, which means reduced stomach acid secretions, that is achlorhydria. This condition which also some of the factors which decreases the iron absorptions. The iron absorption is mainly influenced by the body iron needs and various dietary factors. Usually, these are the certain factors. Based on these factors, we have to take or consume the iron in our day-to-day life. Next one is the causes of iron deficiency. It is mainly divided into certain categories. First one is increased physiological demand. That is the body's requirement for iron increases during the rapid growth in children up to 6 to 24 months. Then in adolescent stage and along with the reproductive age in women due to menstruations. During the menstruation period, there will be some of the iron deficiency or the body needs more iron than the normal regular days. And the second one is pathological blood loss. That will be the chronic blood loss that can lead to iron deficiency. That common it can be causes includes gastrointestinal diseases such as hepatic ulcer, inflammatory bowel disease, and Meckel's diverticulum. And the next one is the parasitic worm infestations. These also may causes the internal bleeding. And the next one is frequent blood sampling, and especially in preterm newborns. And next one is the inadequate iron intake or absorption. Nutritional deficiency is due to the inadequate dietary iron intake. It is the most important cause of iron deficiency in worldwide. Iron absorption may be reduced in conditions such as topical skew, celiac disease, and other gastrectomy. This iron deficiency occurs when the requirements increases, blood loss occurs, or iron take or absorptions are inadequate. Usually, in our day-to-day life, each gram of hemoglobin contains 3.47 milligram of iron. So, loss of each ml of blood may leads to lesser to loss of 0.5 mg of ions. Usually, the bookworms present in the body success 0.032 to 0.2 ml of blood per worm day. Risk factors in development of iron deficiency anemia. Usually, certain groups of people are at higher risk of developing iron deficiency. First one is the age-related factors, that is, the infants, especially premature babies and adolescents, are at high risk because of their rapid growth and increased iron requirements. So, the age is a major risk factors for the development of iron deficiency anemia. The second one is sex. Sex means it is based on the two genders, that is female and male. So women are more prone to iron deficiency due to their menstrual blood loss and increased iron needs during the pregnancy. So based on the male and female category, females are more prone to the iron deficiency anemia. The next one is the drugs. The drugs which is used, mainly the long-term use of aspirin, which is the non-steroidal anti-inflammatory drugs. These drugs are further leads to gastrointestinal bleedings. The gastrointestinal bleeding, and which may leads to the iron loss. Next is the diet patterns, the dietary factors. Usually, the vegetarians and infants fed mainly on the cow's milk may not receive the adequate iron, which may increase in the risk of deficiency. The people who are mostly vegetarians and some of the infants, they will take only the cow's milk as their food. During that conditions, they may lead to certain iron deficiency anemic conditions. Next one is physiological conditions, that is the pregnancy, infancy, adolescence, and the weaning period are associated with increased iron demands. It may be making some more iron deficiency, that is more likely. Usually, the newborn babies are born with relatively high hemoglobin concentrations. During the first 2 to 3 months of life, the hemoglobin level naturally decreases as the red blood cells break down and iron release is stored in the body. And these ions or stores are usually sufficient to support the blood formation for the first 6 to 9 months of the life in a healthy full-term infant. This hemoglobin concentration usually they are born with high hemoglobin concentrations, but during the 2 to 3 months of their life, there will be the decreases in the hemoglobin level, and they may be stores this hemoglobin, which will be useful for the next blood formation for the first 6 to 9 months of their life. However, in low birth weight or premature infants, the iron stores are smaller. Therefore, their iron reserves are depleted much earlier, making them more susceptible to iron deficiency anemia. Full-term infants generally have enough stored iron for the first 6 to 9 months, but the low birth weight and premature infants are at a higher risk of developing iron deficiency because of their iron stores are limited. Clinical manifestation of iron deficiency anemia. It is particularly the hematological manifestations. Mainly, the most important sign is pallor, which refers to the paleness of the skin. and the mucous membranes. However, the pallor usually becomes noticeable only when the hemoglobin level falls to 7 to 8 gram per deciliter. In mild to moderate anemia, the hemoglobin level will be around 6 to 10 gram per deciliter. Patients may show only a few symptoms because the body compensates for the reduced oxygen carrying capacity of the blood. In severe anemia, the hemoglobin will be less than 5 gram per deciliter. Here the symptoms become more prominent and the patients may also develop irritability, loss of appetite, lethargy or extreme tiredness. The heart also works harder to supply the oxygen to the tissues, which may leading to the tachycardia, that is the increased heart rate or systolic flow murmur. In severe anemia, if it's left untreated, it may eventually lead to high output cardiac failure. Pallor is the key sign of iron deficiency anemia, while the severe anemia can cause fatigue, irritability, rapid heartbeat, and even the cardiac complications. Non-hematological manifestation, which may shows that neurological and cognitive impact. Usually, the iron is critical for the brain development and functions. Usually, during the infancy time, the deficiency leads to impaired neurocognitive functions, which can have the long-lasting effects on learning. There is a documented risk of seizures, strokes, and birth holding spells in pediatrics, and it can significantly worsen to restless leg syndrome, impacting sleep and quality of life. These are some of the non-hematological manifestation for the neurocognitive functions. And the next one will be the behavioral changes. That is pica. One of the most distinct signs of iron deficiency is pica. That is the craving to eat a non-nutritive food items. That is pagophagia. This is the specific intense desire to eat the ice, the raw ice. And the next one will be plumbism. Plumbism is nothing but a major clinical concern is that pica can lead patients to ingest lead-containing substance like old paint chips, resulting in lead poisoning. That is plumbism alongside the iron deficiency. Next one will be the physical changes of advanced deficiency. Some of the physical changes we can also identify in non-hematological manifestations, that is cheiliosis and koilonychia. Is koilonychia. That is, first one will be the cheiliosis, that is the painful inflammation and cracking at the corners of the mouth. Will be the cracking in the corners of the mouth. And the next one will be the koilonychia. That is also known as spoon nails, where the nails become thin and concave. These are some of the physical signs in the advanced deficiency of anemia. Preferred treatment of iron deficiency anemia includes the ferrous sulfate. The primary method for treating the iron deficiency is the oral administration of ferrous salt. While the several forms exist, such as the ferrous sulfate, is most commonly and frequently prescribed due to its effectiveness and cost efficiency. Usually, for determining the dosage is not on size on fits it all. It is calculated based on the patient's body weight. So, the standard dose for the elemental iron will be 3 to 6 milligram per kg or D of elemental iron. Here, what first we have to understand what is the elemental iron. It is the critical to distinguish between the weight of the entire salt of the tablet and the actual iron in it. So, the ferrous sulfate contains approximately 20% of the elemental iron by weight. By for optimizing for considering the whole thing, the element iron will be around 20% only in the ferrous salt. So, it will be of 3 to 6 milligram of elemental iron in the whole ferrous salt. Next one is for that we have to optimizing the absorption. The iron is taken significantly between the meals. Ideally, it should be taken between meals. Food, especially dairy or tea, can significantly inhibit the iron absorption. So we have to Avoid taking teas. And the role of juice, the taking iron with juice, especially those with vitamin C like orange juices, highly recommended. Vitamin C creates an acidic environment in the stomach that keeps iron in the ferrous state, making it much easier for the body to absorb. So these are the treatment techniques and optimizing absorption techniques. So to treat the iron deficiency anemia. Next one will be the parenteral iron therapy. Parenteral iron preparations such as iron dextron, which are reserved for the specific clinical situation, because oral therapy is generally as effective, less expensive, and less indication for use. Moreover, these parenteral preparation will be taken when there is small absorptions, persistence ongoing, blood loss, and poor compliance. So first, due to malabsorption, when the body cannot absorb the iron from the digestive tract, we have to give this parenteral iron preparation. And the next will be the persistent ongoing blood loss. When the iron loss exceeds the rate at which it can be replaced orally, we have to take it in a parenteral form. Next is the poor compliance. When the patients are unable to adhere to an oral medical remains, we have to take it into the parenteral iron preparations. Next will be the red cell transfusion. It should be prevent the tissue hypoxia related to anemia, but should be carefully managed to avoid such complications. First, it should only be used when the heart failure is imminent or if the anemia is severe with evidence of substantial ongoing blood loss. Otherwise, we do not do this red cell transfusion. Next will be the unless the active bleeding is present, the transfusion must be given slowly to avoid the precipitating or congestive heart failure due to fluid overload. Usually, there is a restrictive strategy often uses a hemoglobin threshold of 7 to 8 gram per deciliter, though higher thresholds may be used for patients with pre-existing cardiac disease. Based on these, all the complications, we have to undergo these red cell transfusions. So, that is the final decision to take this red cell transfusion for the iron deficiency anemia. Preventing and managing iron deficiency in infants and children involves specific screening, supplementation, and dietary practices. Mainly, we have to undergo routine screening, universal screening for anemia, typically using the hemoglobin or hematocrit, is recommended at 12 months of age. And next will be the high risk screening of around earlier screening for up to 4 or 9 months may be necessary for the infants at increased risk such as to born prematurely or with lower birth weight. So we have to undergo routine screening to prevent this iron deficiency anemia. And the next will be feeding and supplementation. Breastfeed infants for full time exclusively or partially breastfeed infants. Iron supplementation is recommended starting around 4 months of age to ensure the adequate intake of sufficient iron-rich complementary foods such as fortified cereals, etc. Otherwise, we have to use the formula fed infants. Infants should receive iron fortified formula for the first 12 months as as standard formula generally provides sufficient iron. Cow's milk limit. Cow's milk should not be introduced before 12 months of age. After 1 year, intake should be limited to prevent the iron deficiency. Therapy and the follow-up. We have to treatment duration when treating iron deficiency anemia. Iron supplementation is continued for the several months after blood levels normalize to fully replenish the iron stores. We have to follow up is essential to verify response to therapy as hemoglobin levels typically improve first, followed by a gradual increase in ferritin. So these are the certain things we have to follow to prevent this iron deficiency anemia. In this video, we have learned about what is iron deficiency anemia, what is the reasons for the anemia, what are the risk factors of iron deficiency anemia, and how we can prevent this iron deficiency anemia. I hope you all have learned a full structure of this iron deficiency anemia today. Mm, Okay, students, I hope you all have learned about the full description of the iron deficiency anemia. We have learned about what is anemia and what are the types of iron deficiency anemia, how it can be occurs, or what is the etiology of it, how we can prevent this iron deficiency anemia. I hope you all have learned it. We can see in the next class with another disease. Thank you.